Standaert.
All right. Well, good afternoon, and thank you for that great introduction there. I know that was a lot of titles, but I'm a practicing neurologist as well as a neuroscientist. I have worked in Parkinson's disease for quite a few years, and we're going to talk about a topic I think that has really started to change the field, the question of testing for Parkinson's, and is there a test for Parkinson's disease? So I do have a few financial disclosures listed here on the slide. I consult for a number of companies that work in this space and have received research support from some of these companies to do clinical research. I don't think any of this is particularly relevant to what we'll have to say today, but I provide it there for your information. So let's talk a little bit about Parkinson's disease. I always like to start really at the beginning. So at least as far as Western literature goes, Parkinson's disease was identified by Dr. James Parkinson, and he wrote this wonderful book, actually. It's called An Essay on the Shaking Palsy. That's the name he gave to the condition. And he published this in 1817, so more than 200 years ago, where he described many of the features that we still recognize as part of Parkinson's disease. He talked about tremulous motion and a propensity to bend the trunk forward and to go from a walking to a running pace. These are all things that we recognize now, more than 200 years later, as still core symptoms or features of Parkinson's disease. Now, Parkinson's affects a very large number of people, probably more than 1.5 million people in the United States, and somewhere around 4 to 6 million worldwide. So it's actually a very common disorder. These people on the right are some of the public faces that have come out and made a statement about the way Parkinson's has affected them. And I think they are very much become ambassadors for the field. You probably recognize some of these faces over here on the right: Michael J. Fox, Alan Alda, Brian Grant from the NFL, Davis Finney, famous cyclist, the Pope, Linda Ronstadt, Mo Udall, and Muhammad Ali have all played a role in bringing public recognition to Parkinson's disease. And I think they've really done a service for the millions of others who are affected by this condition. So just to think a little bit about Parkinson's and how common it is before we start talking about testing, I think this graph really illustrates an important point about Parkinson's disease, which is the older you get, the more likely you are to develop Parkinson's. So as you know, most Americans alive today can expect to live to be at least 80 years. This is a drastic change. 50 years ago, it wasn't like this at all. So we are living longer. But the older we get, the more likely it is that Parkinson's will develop. And you can see over in this graph on the right that when you're between 0 and 50 years old, it's not such a common condition. Actually, under 30, it's quite rare. But as you turn the corner at 60 to 69 and then to 70 and 79, this becomes a more and more common condition. And it's seen more often in men than in women, which is the two diverging lines there. So that's true at almost any age. So people often ask me, is there more Parkinson's in our population? Is there more in our community? There is, because we're seeing an aging of our community. The baby boomers are approaching that 60 to 69 range where Parkinson's becomes more common. And because of the aging of the baby boomers, we are going to see an increase in the number of people with Parkinson's disease, which I think makes this topic really relevant to everyone. It's very, practically everyone has been touched in some way through a friend or a family by Parkinson's disease. All right, so let's talk just a little bit about the clinical features. There we go. All right. So this is a slide which illustrates some of the classic features. These are the things that we teach our medical students to think about. When you think about the symptoms of Parkinson's disease, we think about these 4 things over here on the left: the resting tremor, bradykinesia, which means slowness of movement, rigidity, which is resistance. When you take a hold of someone's arm and move it, you can feel a resistance, and then postural imbalance, a tendency to fall. And these figures on the right are meant to illustrate some of the range of symptoms that can be seen. In panel B there, women with just some mild problems with the right foot and a little bit of tremor in the hand. more intermediate stage where there may be fluctuations from on and off time, and then what's described as a more diffuse Parkinson's on the right. So these give you a sense of some of the range of the condition in different ways in which it can appear. So next, let's talk a little bit about how neurologists diagnose Parkinson's disease. I get this question a lot. How do you diagnose Parkinson's disease? And really the things we look for, first of all, it's about the history. It's a story that we hear when we talk to patients with Parkinson's and their families. What are we listening for? What are we trying to discover in the history? So usually a complaint of slowness. That's often a common reason for people to come to the neurologist. I'm not walking as fast. I don't keep up with my spouse. Or maybe it's something more focal. My hand doesn't work. My handwriting's gotten very small. Those would be all symptoms of bradykinesia. And then usually there's either resting tremor. This is a very particular type of tremor. It's usually appears in one side first. It's present at rest, meaning when you're not thinking about it. And oftentimes people can suppress this tremor when they put their mind to it. If they focus on the tremor, they can make it go away for a while. Rigidity is really something that the physician feels by moving the body part, moving the arm or moving the leg. And so as a neurologist, to make a diagnosis of Parkinson's disease or Parkinsonism, the symptoms of Parkinson's disease, we are looking for this slowness, bradykinesia, plus either the rest tremor or the rigidity. And so this is the typical criteria that we're using. We're looking for at least two of those three things to be there. We expect it to be gradual in onset. So, Parkinson's doesn't typically begin suddenly. It comes on slowly. And it's almost always asymmetric. It comes on affecting one side more than the other. And this is something we look for. Other things we've learned to look for are some of the things that come well before the Parkinson's disease itself. These are the so-called prodromal features, constipation, which may appear 10 or 20 years before Parkinson's does. REM sleep disorder. This is acting out your dreams at night, being loud, yelling in your sleep, throwing things around, and the loss of sense of smell. And you might say, what do these have to do with Parkinson's? Well, it turns out these are early features which often signal the Parkinson's that is coming. And so when we're talking to someone and we're trying to understand whether their problem is Parkinson's disease, we'll ask about this. And if someone has some rest tremor and some rigidity, maybe they're mild, but they also have constipation, they've been acting out their dreams, they talk in their sleep, and they lost their sense of smell, then the likelihood that this is Parkinson's goes way up. And then, of course, if you've taken the levodopa or a dopamine medicine and it's helped, that's another strong clue that this is Parkinson's. It doesn't typically work in anything else. So those are the things we're looking for in terms of history. And then we usually examine the patient, and what we're looking for there is the resting tremor, the rigidity, and the bradykinesia. So we're looking to see the features that we asked about in the historical section. Now, when do we become more cautious about diagnosis of Parkinson's? Onset before age 40 is unusual. It's not impossible. I've seen patients as young as age 16, but it's very rare to have onset before age 40. And so if the condition begins before age 40, we really take a step back and think very carefully before we make a diagnosis of Parkinson's. Most common age of onset is about 63. And then there's some red flags listed here. These are things, when we hear or see these things, we think, wait, maybe this isn't Parkinson's. Problems with eye movements, that's not common in Parkinson's. Ataxia, which is incoordination, is not common in Parkinson's, nor is muscle atrophy, loss of the bulk of the muscles. Sudden onset, someone says, I woke up one day and I had all these symptoms, that's probably not Parkinson's. Fluctuating symptoms where it's bad one day and gone the next, and then back again the day after, that's not typical either. The muscles usually aren't weak. People get fatigued, they get tired, they may lose strength from inactivity, but paralysis is really not a part of Parkinson's, nor is loss of sensation. Very rapid progression, someone who progressed in a matter of weeks or months, that's probably not Parkinson's either. Falling very early, patients with Parkinson's do fall, but it's usually later in the game. And then severe autonomic symptoms like really severe blood pressure problems early on. So those are all red flags that we look for in terms of trying to think about, well, what are the things that make us step back and ask about alternative diagnosis? So most of the time, the things on the screen here are what I need to make a diagnosis of Parkinson's disease. And I often tell people that even in 2024, the best test for Parkinson's is an experienced movement disorder doctor who's been doing this for a number of years and has seen a lot of people with Parkinson's disease. So there are some tests that people sometimes ask about and that we sometimes use. So first up, things like simple blood tests. Generally speaking, in routine practice, there really isn't a need for any particular blood test when the history and the exam are typical. Now, people ask about genetic testing. There is genetic testing available for Parkinson's disease. Usually that's recommended if there's a very strong family history. What's a strong family history? If you have 7 people or more in your family with Parkinson's, that's a very strong family history. And certainly genetic testing would be warranted there, might be in other settings. Or if you're one of those people with an onset before the age of 40, there are genetic forms that are common in that setting and would be certainly something that's appropriate. Another condition we may test for is a condition called Wilson's disease. Again, you think of this when people have onset before 40, they often have dystonia, fixed posturing, and it usually comes with liver problems. So that would be another clue there. And if you have any of the red flags listing there on the previous slide, that may require some of the other kinds of testing. But when the history and exam are pretty much typical, and there's no particularly strong family history, there really isn't a blood test that needs to be done to diagnose Parkinson's disease. Now, what about MRI? I would say the same thing about that, is that if the history and exam are typical, there's really no reason for an MRI. The changes that are occurring in Parkinson's, the loss of dopamine neurons that are at the root of all this, is not visible in MRI. The MRI in Parkinson's disease is typically normal. So if the history and the exam are fit with Parkinson's, there's really no reason for MRI. Now, if the red flags are present, sudden onset, other kinds of things that don't fit with Parkinson's diagnosis, then an MRI can be very important. And certainly if someone has a history of stroke or other neurologic problems and now develops symptoms of Parkinson's, you may need an MRI to sort out what's going on there. And lastly, lumbar puncture. Typically also not something we would do when the history and exam are typical in clinical diagnosis of Parkinson's disease. So you get the message here that when the history and the exam are typical and about what you expect in Parkinson's, you really don't need a lot of other testing. And my clinic, we often can go quite a long time between having to do extensive testing on patients with Parkinson's. Now, what about newer and more sophisticated tests to look for the changes that do occur in Parkinson's disease? One of the big, I think, advances in this field has been the development of ioflupane, or so-called DAT scan imaging. Some of you may have had this kind of DAT scan. So a regular MRI shows you the structure of the brain. That's really not going to show you the changes that are present in Parkinson's disease. But this is a scan that is specifically testing for the dopamine function, and it is going to show you exactly what's going on with the dopamine function in the brain. So this can be a very useful test. Let's go to the next slide just to talk a little bit about how this works. So one of the things you have to understand how a DAT scan works and why it would be helpful is how the loss of dopamine function relates to the symptoms of Parkinson's disease. And this graph over on the right tries to show this, illustrating time going by on the bottom axis, and then in that big blue curve, the dopamine loss, the amount of dopamine function that you've lost. In Parkinson's, the loss of dopamine from the brain begins many years before the first symptoms appear. I tell people, when I diagnose them with Parkinson's, I say, well, I know this comes as a surprise to you, and maybe this is a shock, but in fact, you've just become aware of this, but you've probably had this problem for 10 years or more. So the loss of dopamine begins at least a decade before the first symptom of the disease appears. And at the time the diagnosis is made, usually at least 50 to 60% of the dopamine neurons are lost. Oftentimes it's more like 70%. So you've lost a lot of dopamine function before you even get to the place where you have any symptoms of Parkinson's. So that's useful in diagnosing it, because these DAT scans measure dopamine function. And so when you measure dopamine function in somebody with early disease, what you find is there's a lot of loss even when the motor symptoms are mild. And this diagram, or this is a set of images here. So this is what the picture you get back when you have a DAT scan. You inject a radioactive dye, it goes into the blood, it spreads to the brain, and it lights up these structures you can see here in the bright yellow and orange and blue. That's the dopamine nerve terminals. The left one is a normal scan, and so that's showing you the normal dopamine nerve terminals in the brain. When Parkinson's is present, those dopamine nerve terminals have dropped off. At least half of them are gone when the symptoms are mild, and more disappear over time. So you get a picture that looks like the one on the right, where there's a dropout of this dopaminergic signal. And this can be a very good test to tell you that there is a dopamine problem in the brain. So how is this useful? Well, let's go to the next slide here. So again, just like the other things, MRI, blood testing, if the clinical features of Parkinson's are really typical and there are no red flags present, you don't need a DAT scan. And I certainly don't get a DAT scan on every patient who comes to see me. It's not something that's really necessary when the picture is typical and as expected. Now, when can you use it? Well, one setting is if someone comes in to see us and they have a tremor, but they really don't have much else in the way of symptoms. There's no bradykinesia, there's no slowness. And the question is this a Parkinson's tremor or some other kind of tremor? Then DAT scan can be very useful to distinguish between these possibilities of it's Parkinson's or it's some other kind of tremor. And then what about settings where it's not really very clear what the diagnosis is? So very mild early symptoms. It can be really tricky to figure out whether it's Parkinson's or just a variant of normal, or this is nothing important. How do you decide? The DAT scan can be useful in that setting. Someone who has some slowness, but there's no tremor at all, that is another setting where you're wondering what's going on, and the DAT scan can be helpful. Sometimes people will try levodopa as a treatment and it won't do very much. And then the question is, well, did they just not get enough? Or are they not responsive to levodopa? The DAT scan can at least help you in the sense of telling you whether there's a dopamine deficit. If there's a dopamine deficit in the brain, working harder with the levodopa may be valuable. If there's nothing wrong with the dopamine system, then levodopa is probably not going to do any good. And other unusual features. So when this diagnosis is unclear or uncertain, are the settings where this could be helpful. One point to make is that if you're going to have an ioflupine scan, one is usually enough. They don't return a number. So you saw those pictures, and the radiologist will read them as normal or abnormal. But you can't really see the change in these, at least not in a short space of time. Now, in a research study, we might repeat them every 2 to 3 years to try to follow the changes in DAT scan over time. But in an individual person, it's really difficult to see. So once you've had a DAT scan and it's abnormal, there's not really a reason to do it again in the future. It's probably going to continue to be abnormal and really not be any different. So typically once is enough with an ioflupine scan. All right, and so how is it useful? I know there's a busy graph over on the right, but let me just make the point here. This is actually a nice article that was published a few years ago that looked at studies where the Parkinsonism was uncertain. So uncertain Parkinsonisms mean people who had some slowness, some stiffness, maybe some tremor, but the physicians involved weren't really sure whether it's Parkinson's disease or not. So they then did a DAT scan and asked, well, what effect did that have? It actually changed the treatment of the patients more than half the time, 54% of the time. And it changed the diagnosis in 31%. So I think this illustrates the point that DAT scan is not needed for the vast majority of people with Parkinson's, but where there's some question about the diagnosis, this can be really valuable. All right, so let's move into the future a little bit and talk about alpha-synuclein based tests for Parkinson's. So this is really the latest innovation in Parkinson's disease, and I think it's really important. This is starting to change the field really dramatically. So you need to know a few things about this protein, alpha-synuclein. So alpha-synuclein is a protein that's normally found in the brain. There's actually quite a lot of it in all of our brains. This is a normal protein that's present in all of us. However, this protein has been linked to Parkinson's through genetic studies, through studying some rare families around the world where they have a genetic form of Parkinson's. They have a strong tendency to inherit this. They found that it can, mutations in the structure of alpha-synuclein can lead to Parkinson's disease. So what it seems to do, and the reason alpha-synuclein is important, is that it aggregates, it misfolds, it clumps up, and these misfolded or abnormal forms of synuclein can be found in most cases of Parkinson's disease. And it makes up something called the Lewy body. You may have heard this term before. This is a picture of a Lewy body over on the right. This is a ball of protein found inside a neuron in the brain. They're not a normal finding. Normal brains don't have these, but you'll find them in people who've had Parkinson's disease or some of the related conditions like Lewy body disease. So these Lewy bodies build up in the neurons. They were described a long time ago. Heinrich Lewy described them probably more than 100 years ago now. But within recent years, in the last 25 years, we've come to realize that what a Lewy body is made of is synuclein. So synuclein is the protein that builds up, and it leads to the formation of these Lewy bodies, which are seen in Parkinson's. So how is this all helpful? How can you use this to test for Parkinson's disease? Well, there's really today 2 ways to do that. So one way is that alpha-synuclein, although it's a brain protein, is also found in nerve cells throughout the body. So there are nerve cells in your skin, in your GI tract, other areas of the body. And so since the alpha-synuclein is found in nerves throughout the body, you can biopsy areas. You can't really biopsy the brain. We don't recommend that, but you can biopsy the skin and you can look for abnormal synuclein. And this is one way you can use a biopsy as a test for Parkinson's disease. The other way is that this abnormal synuclein has so-called seeding properties. So it's a misfolded protein, and when you put it in with other molecules of synuclein, it will seed them. It will grow a crystal, essentially, and that can be used as a way of testing for the presence of alpha-synuclein. So both of these methods are now being used to test for Parkinson's disease. So the first one, this is an example of a skin biopsy. So to do this, typically you take a small biopsy of the skin. This is something similar to what your dermatologist might do. You numb up the skin, you use a little tiny punch, you punch out just a little piece of skin, you send it off to the laboratory, and they stain it to look for abnormal synuclein. So you can see this over on the right. This is a high power magnification of the nerves that are in a piece of skin. The nerves are being lit up in green just to show you where they are, but the red is abnormal synuclein. So the abnormal synuclein builds up in these nerves, and that is really the signature that Parkinson's is present. So this is a useful test to confirm the diagnosis of Parkinson's. It can be negative in some people, so it's positive about 80% of the time, but not necessarily 100. But it does separate Parkinson's from some other rarer diseases like PSP and multiple system atrophy. So that's one test. Another way is to use these so-called seeding assays. And this diagram tries to show a little bit about what this is about. Over on the left, you can see they're using a spinal tap to take fluid from around the spinal cord. Or maybe you can do it from blood. That would be a newer method, still under study. You get a small amount of the synuclein here shown in blue, and then you incubate it. You put it in a tube with more synuclein, which is not aggregated. It's just free in the red particles there. And what that does is it seeds. It's like growing a crystal. If you've ever grown a crystal in high school science class, you know that if you put a seed in, the materials in there can crystallize out and grow, and you're growing a crystal of synuclein here. And so what you can do is do that in a cyclic way, where you grow the crystal, you break them up a little bit, put them in with more synuclein, and you get progressive seeding. And this really is detecting this abnormal form of synuclein. This is a very powerful test and can take a tiny amount of synuclein from the body and generate a really big signal that we can see as a test for Parkinson's. So this illustrates some of the kinds of results you can see. This was the original study, I think, that really brought this all to our attention, published in 2017. And you can see some numbers here. How sensitive is this to test for Parkinson's? Well, it picks up 88% of the Parkinson's cases. It picks up all the DLB, the dementia with Lewy body cases. Can also pick up things like MSA. And it's about 96% specific, meaning it's positive in Parkinson's, but it's only very rarely positive in people who don't have Parkinson's. And then this is a much bigger study, and I would say this is the one that really put it on the map, published in 2023. This is a large study funded largely by the Michael J. Fox Foundation for Parkinson's Research. They're calling this now seeding activity assays, or SAA. You'll see that term used. They tested more than 1,000 people in the Fox Foundation's PPMI study. They found it's positive in 87% of the Parkinson's patients and less than 4% of the controls. So this is really separating Parkinson's from controls. And it shows you that most of the cases of Parkinson's are related to synuclein. Now, obviously, there's a few people who test negative. They seem to have symptoms of Parkinson's and they test negative. What's going on there? That's something we'd like to learn more about. And you have 4% of controls testing positive. But that could be, some of those could be people that are going to get Parkinson's at some date in the future. So a lot more to learn about this, but a really powerful test to separate PD from control. All right, so that's all done from spinal fluid. And while spinal fluid is neurologists like to test that because it surrounds the brain, it bathes the brain. It's a very direct test of the brain. Having a spinal tap we do it very often. It's safe, but it's not particularly convenient, and most people would prefer not to have that procedure. So could we find something easier? So this is using skin, so taking skin biopsies, and rather than staining it like I showed in the earlier picture, now they're using it as a source of the seeding, and this does work. It's more positive if you do it closer to the head, makes some sense. So from the neck versus the arm or the leg. So this may become a useful method. And then lastly, what about the blood? And we're so used to having blood tests, right? So we go to the doctor, we have a blood test. Why not a blood test for Parkinson's? And so this is some really interesting work from a group in Japan showing that they've developed a method to test for this in blood. And they're positive in 95% of Parkinson's disease. So that's pretty remarkable. And this kind of work is still going on to optimize this and to really get this to where we can use it routinely. But we may get to a day where you can just go to the doctor and have a blood test to see if you have synuclein seeds. And that will be a really remarkable moment in the history of all this. One point I did want to make, some people ask about multiple system atrophy. This is a condition which can be confused with Parkinson's. And this test can actually separate that and tell us which people have PD and which have MSA. All right, so let me summarize some key points about this SAA, or seeding activity assay. So first of all, it's a really powerful way to detect abnormal synuclein in Parkinson's. Most people who have Parkinson's, and sporadic means it's not a strongly familial form, it's a case that just appeared with no particular history, will have positive SAA assays. If you look at people with conditions that create risk for Parkinson's, like REM behavior disorder, that acting out of your dreams, many people will be positive. They don't yet have symptoms of Parkinson's, but they're probably on their way to developing those, and they will be positive before the Parkinson's symptoms appear. They can separate Parkinson's from some of these other conditions like PSP, corticobasal degeneration, and even Alzheimer's disease. They may be able to distinguish PD from MSA, which is a bit tougher. MSA also involves synuclein, but apparently a different kind of synuclein. And lastly, it's what we call a state marker. It shows that this synuclein is there, but it doesn't measure how much. It doesn't tell you how fast the disease is progressing. It's just a sort of black and white yes or no answer that you get from an SAA test, at least the current ones that we do today. All right, so that leads to kind of a new way of thinking about the progression of Parkinson's disease. I really think the way we should think about this is that there are a group of people who are at risk. These are people who have no symptoms at all, but maybe they have some genetic risk factors. They have some genetic triggers that may lead ultimately to Parkinson's. Then there's a group that have so-called prodromal Parkinson's disease. Things that would put you in this category would include loss of the sense of smell, REM behavior disorder, acting out your dreams at night, constipation. And then early Parkinson's associated with the things we've discussed, like tremor, bradykinesia, rigidity, and fatigue. And then more advanced Parkinson's, where there's impaired balance, wearing off, dyskinesia, memory problems, and hallucinations. So this is really thinking of this as a continuum of symptoms, starting all the way from no symptoms at all to more advanced ones. And so what about seeds? And we talked about seeds in people who have Parkinson's. Can you find seeds in people who are just at risk? And actually you can. If you test people who have loss of the sense of smell or REM behavior disorder, 86% are positive. So again, seeding is taking us to a day when we may be able to detect people before they develop the symptoms of Parkinson's. And this is I think the view that scientists are starting to take of this disease, which is really quite different than the way we thought about the field when I started. So this is a staging system that's been suggested, starting all the way over on the left at stage 0, where there's no symptoms and maybe people have a gene that puts them at risk, but there's no neurologic symptom at all. In a middle stage, what you have developing is the appearance of abnormal synuclein, that's in the red curve. And following that, you get loss of dopamine function, that's in the blue curve. But both of those things go on for quite a while before there are any detectable signs that the person has Parkinson's. And then when they cross that line that's on the right there is when functional impairment begins. So you can have presence of synuclein seeds, you can have abnormal dopamine function, but you still have no symptoms at all. The symptoms appear later in the game. This is really an important idea because it takes us to the thought that not only are we looking for a treatment for Parkinson's, we're starting to talk about prevention of Parkinson's. Can we find ways to do something about these seeds or change the dopamine degeneration in this left or middle box where there are no symptoms? If you can do that, it's essentially a prevention or a cure for Parkinson's. And so this is where this work is taking the field, I think, in a really very promising direction. All right, so let me conclude with some practical thoughts about this. So the first point is when the history and symptoms of Parkinson's are typical, there really isn't a test that's needed. Many patients, we can make the diagnosis with no test at all. So that's an important point to remember. If there's something unusual, there red flags are present, then usually at least MRI imaging, sometimes some blood tests are used to look for alternate explanations for the symptoms. Ioflupane or DAT scan is really helpful when the diagnosis is uncertain. And I thought I'd make the point that this is a test that is usually covered by insurance. Now, my degree is in medicine, not insurance, so I can't answer to all insurance questions. But generally speaking, I have found most often this test gets covered by insurance. Skin biopsy can be helpful to distinguish Parkinson's, which usually has abnormal synuclein from other conditions. That's a test we found is sometimes covered, but sometimes not. Depends on the insurance company. And you should certainly ask your doctor about that if you're thinking about having that kind of testing. And then seeding assays are really powerful. And this is a very powerful method for testing for abnormal synuclein. Generally currently not covered by insurance. It does require a lumbar puncture to do the test, which is currently available, although this may change soon. And then lastly, some of these tests can detect Parkinson's before the symptoms appear. I think this is something that is important in the research field, but it's really not something we're ready to do in a clinical setting. I don't think there's, if we have a treatment to offer someone, then it's very important to do early detection. But we're not quite there yet. This is something we're looking for. It's where the effort and energy is in research, is looking for treatments that could be applied before the symptoms appear. But aside from being in a research study, I don't recommend testing for Parkinson's when there really aren't any symptoms. All right, so I will conclude my comments there, and I'm happy to take some questions.
Dr. Standaert, thank you so much for that informative presentation. And I do have some questions that have been submitted from the audience. The first question is, what do you as a clinician wish existed to aid in early detection or follow-up and disease tracking after a diagnosis has been made? What is the most unmet need?
Well, in terms of disease, following the disease, the big question is, how do we measure how this disease changes over time? And I think that's important in two respects. One is simply to help both the physician and the patient understand, how is my condition changing? The other important aspect of that is, if I have a drug, if I find a treatment, I find something that works in the lab, it works in mice, it prevents Parkinson's in mice, and I want to test that in patients. How do I know it's working? If I take some people who have mild Parkinson's and I put them on a drug and I wait to see whether their Parkinson's progresses, both fortunately it's a slow disease, but from a research perspective, that means we have to wait a long time. It's very hard right now to do a study of Parkinson's that lasts less than 2 or 3 years. And that's a long time. I'd like to have a method to follow the Parkinson's that we could use in a much shorter space of time and accurately measure what's going on in the brain. We really don't have that yet.
Thank you. Another question from the audience says, my father, aunt, and first cousin have PD. I don't think I have any symptoms. Should I ask my doctor for one of the tests that you talked about so that I can know if PD is in my future?
I don't think you would want to do seeding activity or DAT scan. Now, depending on the two alternatives, one is many times we just suggest people go and see a neurologist and have an examination just to find out whether there are any symptoms there or not. Sometimes a neurologist will pick up on things that you may not be aware of. So that would be one relatively simple step. There is genetic testing available. And so if there's a strong family history and you want to know more about that, there are genetic tests. And there are, at least in the pipeline, I think in the future, we will have treatments based on the results of those genetic tests. So if you truly have a strong family history, genetic testing might be worthwhile.
Thank you. And our next question is from a healthcare professional. And this is an occupational therapist who works with many PD patients. Many of them have heard of these tests and they want to know if they should ask their neurologist to test them, specifically the patients who are unsure if the PD diagnosis is correct. And she has patients who are not responsive to levodopa but have several PD symptoms. And would you recommend that these patients seek further testing?
Well, I think when the Parkinson's is not behaving in the way that is typical or the way the neurologist expects, it's good to think about more testing. In particular, if you have a situation where levodopa doesn't seem to be doing anything, you would wonder if there's a dopamine problem at all. And DAT scan is a useful technique there to actually ask, well, is there actually a dopamine loss in the brain? If there's no dopamine deficiency, then levodopa isn't going to do anything. And so that's a setting where I would consider that kind of testing.
Thank you. And our next question asks, even if a test shows that a Parkinsonian disease is present, what does early detection really accomplish? Because it's not like early detection means someone can halt Parkinson's. Wouldn't it just make people stressed?
Well, I do agree that we don't, that doing a test when you can't act on it is not really that helpful. And that's why testing in a case of somebody who has no symptoms at all, I wouldn't recommend that unless you're in a research study. Now, on the other hand, does early detection of Parkinson's symptoms, is that valuable? What can you do? Well, there are things you can do. Actually, what we recommend is really an exercise and wellness approach. If you ask me today, what treatment or intervention has been shown to positively benefit patients with Parkinson's and slow the progression of symptoms, it would actually be exercise. Is by far the best evidence right now today, much better than any supplement or any drug that we've tested yet. So people who have very mild early symptoms of Parkinson's, I recommend a real focus on exercise, developing an exercise program, and a focus on personal wellness. Now, I'd like to see a day come when we actually have a treatment which directly slows the condition. But until we do, exercise is incredibly valuable and is something we should remember that that's available and accessible to most people and can make a big difference.
Thank you. And our next question from the audience is, what proven biomarkers can be used now to detect Parkinson's, and why couldn't such markers be used to speed up Parkinson's drug development?
Right. So, I mean, I think the biomarkers that are proven, certainly the DAT scan shows you dopamine cell loss. And the synuclein seeding assay is new, but it detects most forms of Parkinson's, certainly those which are caused by abnormal synucleins. And they are speeding up the drug development process. So now these days, most of the time when you enter a study of Parkinson's treatment, they're going to want a DAT scan to confirm the diagnosis. Because one of the things we've learned from clinical trials is if you don't have the diagnosis right, then the treatment's probably not going to work. And that can really cause trouble with your clinical trial. If some of the people in your study don't have the right condition, that can really interfere with getting a clean signal at the end and finding the right answer. In terms of seeding activity assays, these are becoming more common in both developing populations for testing drugs. And in fact, people are making antibodies and other treatments to try and remove the abnormal synuclein. So, a lot of this is pretty new. Certainly the seeding activity, I think, really only became widely accepted in the community in the last year. So it's early days, but I think it really is starting to drive discovery of treatments for Parkinson's.
Wonderful. Well, that is all the time we have. So I want to thank Dr. Standaert for sharing his expertise with us and to our audience for being with us this afternoon. We hope you have a wonderful rest of your day, and we look forward to seeing you at future APDA programs. You can visit our website at apdaparkinson.org for additional information and resources.
All right.
I'm Leslie Chambers, President and CEO of the American Parkinson Disease Association. Thank you so much for joining us today on our program. Every day, APDA is committed to providing helpful programs just like this one, as well as a wide variety of support groups, exercise classes, and educational programs to support the Parkinson's disease community. Whether online or in person, APDA is here for you every step of the way. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. We keep you posted on our social media channels as well, so make sure you follow us there. You can also connect to local resources and events through our nationwide network of chapters and information and referral centers. Remember, we're just a click or a phone call away. If you've enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Every gift, large or small, helps APDA support people living with PD through thoughtful programming, reliable resources, groundbreaking research, and more. Please visit apdaparkinson.org/donate today to support our critical work for those with Parkinson's. We are so grateful for your generosity. Thank you.